So welcome everybody. Sorry for the late start. It was me, I got stuck. I'm not going to spend too much time talking about me or doing a long introduction. We've got quite a lot to get through. So I'm going to move straight on to my first presentation really, which is just to help us think about what we think equity and means for us in health and care across the life course. Are we thinking enough about equity as described in today's meetings? Are we thinking enough intersectionally about different types? What could we do better? What could we do more of? Have we got the right approach? So I open up the discussion to the floor, because it's your views I want to hear. So please wave your hand or just shout out, and we'll spend around 10 minutes just talking this through, if that's okay with everybody. What does equity mean to you? How are we doing it? Could we be doing other things? Should we be focusing on it more directly, or have we got the balance about right? Okay, one of our challenges is that we should, because we're in the north and because we're in areas of high deprivation, NIHR has asked us to make sure that we do our best to understand the needs of populations with the most pressing needs and the organizations that are there to deliver those needs. And I wonder if you think we're doing that at the moment. I'm not convinced we're always doing it correctly, and I think we're quite good at public advisors as individuals. I'm not quite sure how well we're reaching into communities, particularly across the life course. I know we have the Seldom Heard Voices Network, which is a way to start that process, but I wonder what colleagues felt. Are we missing some tricks? Could we work more with the equitable place-based health and care theme, for example, or what used to be called neighbourhoods for learning? I see there's a question there from Richa. Richa, do you want to talk to us about that? If you feel able to. Just unmute. And
yeah, I've worked out where the unmute button is. Hi, I'm Risha Gupta. I'm a consultant neonatologist working at Lancashire Teaching Hospitals. So our difficulty really is, equity sort of, to me, kind of means some kind of fairness. But fairness doesn't necessarily mean that you're giving the same to everybody, because every person, individual or part of populations, have their own needs. So is it really about what are the ultimate outcomes that we want to achieve that are kind of consistent across people and populations? And I suppose, do we work backwards from that by saying, look, these are the standards and the clinical outcomes that we aspire to achieve, but how do we ensure that the various populations where they're the differences in their health, their access to health, how can they all be able to achieve those same kind of high standards of care? I don't know, is that—
Thank you. So an important point, and I'm going to challenge you a bit back and work backwards. That's quite understandably, that's they may not share that as their principal goal. So we may feel that this is actually all about standard of care, access to care, and actually for people living in areas they may have more basic needs. They may not be accessing much care at all, or the care that we're offering may not meet their priorities and their needs. So one of the challenges we have is about bringing those together. This is what we offer, but are we offering a flexible enough or a wide enough system? That would be my response to that. Certainly the provider organizations should definitely be asking, what does our population access to our services look like? Is it what we would expect from what we know of the people that live in this area? Are they fairly represented by the people that are coming to our service? Or are there gaps from different communities that we would expect to see here, but that we're not seeing, and what is that about? So that's certainly, and also looking at their experience of our service. I think that's what you're talking about, Risha. But I guess we're saying, Edward.
If I may comment, first of all, I entirely agree. We cannot just simply apply our priorities and see them as priorities of everyone. And we need to listen to their voices. And I wonder whether the current ethics considerations are appropriate for that. Some people would struggle to read the informed letter, signed consent. They may not come back to that. They may not have literacy to understand even the simple language. And for some communities to reach them, we probably just need to talk to them and get them verbal consent or some other measures so that we don't exclude them.
Indeed, very good point, Edward. And the move towards everything going online and being digital, I think, is also a question that we have about whether all communities are accessing or able to equally access digital in the way that we expect, particularly if they have the literacy problems or financial problems or a whole host of other reasons why that might not be the best way to talk to them. So
yeah, I mean, I agree. Just coming back on that, because part of was certainly the project I'm involved with, Nest at Home. We haven't presented this time. Maybe next time, is about co-production, and the starting point for us through the clerk was to get families and parents understanding of or their perceptions of the service as they saw it, and then what they felt that they needed. So, you know, our outcome was, how do we safely get babies home? And they brought their perspectives in a lot of sense of the experience they had that we obviously weren't aware of. And so I think involving the users of the service in helping developing our perspectives of what kind of service we want to have, and gathering that in a structured evidence-based way is where I find that the ARC has actually been very useful for us as a sort of a framework approach to that collaboration with parents.
Yeah, thank you. I can see Dorcas's hand up. Yeah.
Yes, thank you so much. I just want to support what they've been saying about equity, really. When you look at equity and equality, you want to identify the needs of the community or the patients before you can say you are giving them the right choice to their health, or are they assessing the health in an equal way. And I think we have to move back a little bit to see how we can reach the community, to see what their needs are, before we can say we're providing equity and equality care for them.
Thank you. Yes, that's right. And that's the challenges that we face. Is we have a wide geographical area with lots of different types of populations and population mixes across. Alan, is that your hand up?
Yeah, yes, it is, Mark. Am I on? Can you hear me?
Yes, you are on.
I was wondering how some of the work that we're doing in ARC, not just this topic, but more generally, how it's being integrated in any way with the developing ICSs in the region. There are all sorts of partnerships that look very much similar to some of the work that's being conducted in ARC.
Well, we are
wondering what cross-fertilization might be.
So the integrated care systems, and everybody will know what they are. And in fact, integrated care boards is now another term that's coming on into play here. They are the new NHS and social care structures that are regional. So we have two in the Northwest Coast. We have the Cheshire and Mersey Integrated Care Board, and we have the Healthier Lancashire South Cumbria, which is the north of the patch that takes us up as far as Kendal. And their role is they've taken over from the CCGs, essentially. They'll be commissioning all the health and social care services and coordinating health and social care across these geographical areas on behalf of the Department of Health and Social Care. And they are coming into being. They've got new chief executives, and we are working very closely with colleagues to bring them into our discussions, so that they're aware that what we're doing in R&D and how we can work with them they've both gone to look at equity by getting Marmot commissions. And we're involved in both of those as well. So at that level too, Alan and colleagues, we are doing our best to make sure that we have shared spaces to talk about these things. Right, so I'm going to stop now, unless there's any more comment, because I think we should move on to the next section. And we can come back to this when we've heard our, unless anybody else has anything they want to add just now. We can come back to this at the end when people have had a chance to listen and think a little more. So, Pallavi, are you able to take us on to Dorcas's presentation?
Good morning, everyone. My name is Dorcas Akeju, and I'm a retired midwife with different volunteering roles. I joined the clerk, now ARC, in 2015, and I've been involved in projects and researches as a public advisor. But now I'm co-lead for F and Care Across Life course, for short, ARCFEST. My passion has always been for the right of women and girls, and that passion continues as a surrectomist, whose vision is to empower, educate, and enable women and girls all over the world. I've become more interested in domestic violence as women and girls are still being abused in different ways, from sexual exploitation to trafficking. Next slide, please. Next slide. Definition. Domestic violence is also known as domestic abuse or family abuse. It's violence or other abuse in domestic setting, such as in marriage and cohabitation. So it could be in marriage or people cohabiting or people living together as same-sex partners. Often committed by one of the intimate relationship against the other person. The United States also define it as against women and an act of gender-based violence that result in or likely to result in physical, sexual, or mental harm or suffering to women, including threats of such acts, coercion, arbitrary deprivation of liberty, in public or in private. It could be happening anywhere. So this domestic violence is not just something that you may not say it, but it's happening. And that's important that we should at least address the issue. Next slide, please. It takes all sorts of different formats, really. And people, I know you are aware of that, but it is important. I mentioned this. Physical, this could be from other person using a knife or killing the other person. And recently, we've had news about that policewoman that was killed. Verbal, derogatory words such as calling the person useless, worthless. When a partner is saying that to the other partner, is that good? Sexual abuse through rape or through female genital mutilation. Emotional, in which the person is being ignored in the house. Economic, when there is no money, she hasn't got money to spend, and the other partner is refusing to give money, so she can't even survive. And the religious one, it could be somebody in one religion doesn't want the other person to marry the other religion. And we had this story about that one, about the incident that happened in the Northwest a long time ago. Reproductive, that could be due to damage during the FGM, female genital mutilation to the vagina. And so the woman won't be able to have intercourse. Neither can she have children. Next slide, please. The history of domestic violence has been a long, long time. It's not something new. Over 2,000 years ago, it was condoned. Even the Roman law gave a man life and death authority over his wife in the 18th century. And the girls were prostitutes in 1800 and trafficked. And now we have girls being trafficked. We still have sexual trafficking. So you can see it has no change. And this was written by Rod Gardner in his book, Joseph Butler, who tried to save these young girls and keeping them in a house. Even the English law, you won't believe how we gave a man to discipline his wife and children with a stick or a whip no wider than his thumb. And I saw that online. I thought, this is still good. This has been going on for a long time, and it's still going on. What can we do about it? What's happening since 2000 a year ago and 1870, and we still have it? Next slide, please. So as you realize the scope of problem, it's worldwide. It's worldwide, not just in England, in Africa. The prevalence data in 2000 to 2018 was done of about 161 countries, found that worldwide, 1.3 or 30% of women have been subjected to physical and sexual violence. This was a research carried out by World Health Organization on behalf of United Nations Interagency throughout all the world. I'm not saying men are not being abused, but what I'm trying to address here is the inequality that is more common among women than men, and is it because of all the power the men have got? According to the Crime Survey for England and Wales, year ending March 2021, estimated 5.5% of adults aged 16 to 74 and 2.3 million experienced domestic violence. Can you imagine that in that year alone? And since the coronavirus, this has gone up. Is it because of the lockdown? So the couple, the family, they all stuck together in the house, so getting up on another, and this has increased the calls to the police, 206.492 domestic violence calls. You can see the incident. It's not going down and it's going up. And I know there's been a lot of research, a lot of papers written about it, but why is it going on? What can we do? We want to say, even within Merseyside, what's going on. By a year into pandemic, in November, 1.6 million of women and 757,000 of men experience domestic violence. It has been noticed that when there is a major football match, there's usually increase in domestic violence too, which is very, very interesting. The above has highlighted the fact that women have always been seen not equal to men. And as we are talking about inequalities and equity at the moment, this domestic violence is something we need to address. Next slide, please. It's got a lot of impact because when there's domestic violence, it's long-term and short-term. And the person who has been abused can never forget the physical and reproductive and psychological consequences. That was written by Jean and Thomas in 2013. The mental health problem, because these women or men, sometimes they have it in their head and they cannot tell anybody. They're frightened to tell people because they felt they'd be more abused. Even as a midwife, when I was at the women's, I've seen that. And that's not long ago, and it's still happening. The sexual abuse, rape, and female genital mutilation. Female genital mutilation, you might say, oh, it's only happening in Africa. But no, because we do get, people coming from Africa, and we have to support them. And we do get family that think it's the culture. So that's why we need to address this. Social and economic impact, as I've explained before. If you don't give money to the woman to spend on food, how is she going to feed? How is she going to feed her family? If the husband is punishing the woman or the partner is punishing the woman. So it is important that we address this. And to be honest, really, it's the impact throughout life that I look at, because when there is abuse from early marriage or early living together, that stays with the man or the woman forever. Next slide, please. The future plan what we're looking at now, I've been working with the National Priority Program, and it was set up by ARCFEST, you know, and some are not teams as well. So we're looking into this social, the social worker and the social work, how this could be addressed really, integrating everything together, and the healthcare system, because it's the response that you get from the woman that will lead to the care of the woman. We set up a sports planning group consisting of public advisors like me and managers, and we're looking into maybe doing a little research to find out around our region the incidence, how big it is, this issue, and what are the services available, and are there gaps, are there inequality in the services? So we need to know that. The focus group will be in early 2022. So we will let people know if they want to join us. In conclusion, next slide, please. Reading through some papers, they did highlight the inequality between men and women in relationship. You might say, you know, what is something, you know, people live together, and that's common among maybe some cultures in which if they got children, they stay with the men, even though there is abuse. Some white people where they stay with their men, even though they've been abused. So it is important that, you know, this inequality, we break it. I'm not saying that generally inequalities are reducing. I was the Equality and Diversity Lead for my trust in 2010, and I did the policy about equality and diversity. You know, so I know what I'm talking about. So we know it's reducing. Now we have even women becoming a pastor, or reverend, or women becoming leaders. Even look at us in Liverpool, we have women councillors, women chief police. So it is reducing. But there is a need to find out why domestic abuse continues. If generally we have the inequality reduced on one side, why can't we reduce domestic abuse and still continue? To ensure equity service so that survivors and perpetrators are supported. There are a lot of voluntary organizations, but with the lockdown and with the services being reduced, it does have an impact on them as well to reach those that are survivors or to support the victims. We need to look into all that, and that's why we're hoping to do a little survey as well. Although generally there is a need as well to look into why people are being abused. Is it because we need to support those perpetrators as well? So that's important. Next slide, please. I've been reading a lot of papers. These are some references for you. You may have over papers that you've read about domestic violence. So if you have any at all, if you think, oh, this is something you are passionate about, this is something you want to be part of, you can always email me on my email address, you know, which will come on the slide in a minute, and then you can, you can join our focus group in next year if you want to just guide us on what's happening out there, because we don't know what's happening. I'm just talking to voluntary service in the SDLA, they call South Liverpool Domestic Violence Service in Garston. I've been there to talk to them, and I'm talking to other people to see what's going on. So it would be important for us to come together to see what's going on in Liverpool, and now we can reduce domestic violence. And that's just it. I've only just a short time to talk, so thank you very much for listening. Any ideas or views, you can see my email address. Thank you for listening.
Okay,
Hi, my name is Clarissa Giebel, and I'm a Senior Research Fellow in the HaCAL team. Today, I'm going to give you a very brief overview of how I and my team members are involving people with dementia and carers equitably in our research. So when we think about inequalities and ensuring equity in general, and specifically equity in dementia and aging and accessing care, there are a number of barriers that are not specific to people living with dementia or older adults, but they're generally out there. So they include being from a minority ethnic background, living in a more rural area, perhaps, as opposed to an urban area, but also it can mean living in a different postcode that can really determine what type of care you get, or really living within the north of a city as opposed to the south of the city. Your gender might determine what type of care you access, as well as your financial means, but also education. So some of these factors are particularly pronounced as barriers in accessing dementia care and care in general for unpaid carers. But there are also specific types of barriers for people with the condition or older adults more generally. So if someone with dementia or an older person is living alone, they may struggle particularly in knowing where to seek help and when to seek help, specifically as we live now in a more digitalized age. So we found in our research that people with dementia, older people who are living with an adult child carer, so their son or their daughter, or getting the support from them, are much better supported than someone living on their own, because the family carers tend to be more proactive. They have to be in order to access care, unfortunately, but then they know when and where to seek help. As I mentioned, there's the digital literacy or illiteracy issue as well, and also thinking about older people with cognitive deficits. There's the issue of the cognitive resources used to engage in remote support. So again, if we think about, oh, suddenly everything's remotely, everything's via Zoom or Teams, then many people with dementia or other cognitive deficits can struggle in getting that support. Again, it's another barrier to accessing good care, which can result in poor health and poor mental health, so in poorer health outcomes. There can also be particularly research that we've done in dementia in terms of the preferences and types of support. Some people might prefer one-on-one support as opposed to groups. This can also be gender-based, or they're different preferences, basically. So it's really about what the individual wants. Now, we have done research into the inequalities in dementia care, and we know that these are barriers to accessing good care and having good health outcomes. But really, it's important to have people living with a condition, people who are caring for someone, but also professionals providing care, equitably involved in all of this research to make sure that we address these points or specific key points as best as possible to really tackle the needs of people with a condition, of people caring for a loved one with dementia. So how to equitably involve people with dementia and unpaid carers, but also care providers. So in terms of people living with a condition and caring for someone with a condition, I'm purposefully trying to recruit new public advisors from different sources regularly. So not every month or so, but really, for example, if we have a new big project coming up, or if I know that the majority of our current carers and people with dementia on the register are already engaged in a lot of research. So I'm trying to get new people involved because they bring really, I suppose, fresh thoughts, fresh experiences and different experiences. And it also allows that the pool of public advisors is more representative of the needs and experiences of people out there. And I recruit people from different sources, so either via clinical contacts, but also via social care organizations, third sector organizations, and not always the same, but really trying to be as broad and diverse as possible. And as I just mentioned, it's about sharing these opportunities that come up equally amongst PAs. So it's not just about two very keen public advisors continuously being involved, but really sharing out those opportunities. And I suppose also once we are actively doing research, trying to make sure that we set meetings and activities when public advisors are available to really ensure everyone can take part. Obviously though, I don't think we can ever be truly equitable with remote engagement, which has particularly come up obviously during the pandemic. ideally, we'd love to hear from people, from older people, from people with dementia, for this specific example, that aren't digitally literate, that live on their own, might be really socially isolated and really don't engage with services. We would love to have them involved as well. But as mentioned, if they are so isolated as well, it's very difficult to get a hold of them. But we're trying to really engage a diverse sample, a diverse representation of carers. So how are public advisors involved in our research? They are involved in every single step of the research process, which is an absolute pleasure to be working with the carers and people with the condition, and providers as well. So if we have an idea, often the idea comes up from chats with carers that then turn into a research idea, and then we have team meetings and really conceptualize those ideas. Then it's off to the grant applications. If we are lucky to get the funding, people are equitably involved in the team meetings. They're equal team members and have an equal, I suppose, voting right in decision making. Their opinions are as important as that of any other team member. They contribute to shaping study documents. So, for example, when we design surveys or topic guides for qualitative work, they really look at what we ask. Is it really looking at what we want to ask to bring out those inequality angles, which is part of all of our research, for example, and also whether how we ask the questions, is it user-friendly to ensure uptake of the survey or uptake and completion of an interview, for example. Many help with recruitment as well, and we've also had people help us with the actual analysis, so reading through transcripts, but also obviously with the interpretation of findings. Everyone gets involved with that, through to the dissemination and writing lay summaries, but also being co-authors on all of our publications. And one example of a particular outreach work or public involvement work, trying to engage people from diverse backgrounds, is via the Liverpool Dementia and Aging Research Forum. So I set this up in 2019. Many of you will hopefully know that about by now. And the forum has really come to life because when I started in Liverpool a few years ago, I noticed that there were pockets of people who may know one another, but no proper connection. And also what I'm really keen about is that we share the work that's going on with people that are affected by the condition and with the general public. So if there's new research, if there's new services, treatments, etc., I'm keen for people that are living with this condition and caring for someone to really have access to that knowledge and discuss that knowledge in a really friendly, open space. So what I'm doing is, it first really started with every 2 months having free public talks, which are followed up after the talks with a general Q&A. So people living with dementia, care providers, and the public can just ask questions to the speaker. There's also monthly journal clubs. Everyone's welcome. If someone would like to get involved, let me know. And because of the pandemic, I've also set up virtually twice a year, a regional networking meeting. So for people in the Liverpool region and beyond, to share new research, new opportunities, new services that are out there, new care providers, just to link up and really be aware what's going on in our region. And obviously also the annual conference every autumn. And this is a picture taken of a public consultation group in a pre-pandemic forum in January 2019. And this is made up of lots of unpaid carers. We've got a few clinical psychologists in the picture as well, and some people with dementia. And that was really an opportunity for people to share more broadly what they are interested in looking at in terms of research, what should be focused on, what's their needs, what's their wishes. And just to highlight an example here from the COVID-19 dementia research, we conducted 2 linked up studies, one looking at community, one looking at care homes. And to summarize across those 2 studies, which took place in the past 18 months, 4 carers and 1 person living with dementia was involved. 7 different NHS and social care organisations were involved, all as equal team members, and that has led to 11 publications so far. 3 are still under review, an enormous amount of output, but it wouldn't have been possible without the solid input and equal input of people with the lived experiences and people with the professional and voluntary experiences of dementia and aging. So here you can see as well a couple of examples of those papers. Again, everyone is a co-author on this as well. And just to finish off this talk, these studies and having this equitable involvement of people with the conditions and caring for people with the conditions has also led to 2 policy briefs in collaboration with the Liverpool Heseltine Institute. One focusing on the community angle of the findings and one focusing on the care home practices angle. Again, it really wouldn't have been possible to even draw these conclusions, to frame them in the context of what's actually happening if we had just been academics. So it's really important, and I suppose a big shout out as part of this presentation to say thank you for the continued involvement of everyone in this research, and I hope people will stay involved with future research. Thank you very much.
Thank you very much indeed for giving me the opportunity to present some very, very preliminary thoughts about how we might grow inequalities research in the theme and the sub-theme of family and children in HaCAL. These are very early thoughts, and I would certainly welcome your reflections on how appropriate they are and alternative strategies that might be developed. My name is Jo Blair. I'm a paediatric endocrinologist at Alder Hey, and therefore my view naturally comes from within a healthcare setting, but I fully understand that we need to embrace all professionals involved in the growth and development of our children and their families if this is to be successful. I've worked in a number of different geographical areas where health inequalities have had a profound impact on the welfare of our children, including in the northeast of Scotland and in Glasgow, the east end of London, and of course currently in Liverpool. And I feel very strongly that this is an area that we cannot fail to address in the years going forwards. And of course, it's not possible to talk about health inequalities affecting children today without referencing this very important report entitled Child of the North. And I'm sure many people here will have seen the press releases over the last few days. And this is a quote from the one of the co-authors, Lem Sisse, who also wrote the foreword for the report. And he says very clearly that inequalities has been shown to be one of the most damaging things to society. And this report is a call to government, to educators, and to all of us who are participants of this society to our duty to gift our children equality, no matter where they are born. And the report goes on to make a number of recommendations for changes that need to be addressed at a national and a government level, but nevertheless it clearly identifies areas that research is required to really understand what evaluations are necessary to understand the impact of those interventions. And of course this report was co-authored by Professor Taylor Robinson, who really has been leading the way in understanding the impact of health inequalities on our patients and children. So I thought it would be helpful just to give a few headlights to inspire everybody here, and I'm sure people don't need to be inspired because you're all here already, but nevertheless some of these are data which won't surprise people, but I think the magnitude of the impact of the pandemic is really startling. So compared to the rest of England, children living in the north are more likely to die under the age of 1, to be living in local authority care, to be obese, and to live in poverty. And I think most of us were very familiar with these adverse effects already, but the impact of the pandemic is really stunning. During the pandemic, children living in the north were more likely to be reported as being often lonely, and I wondered whether this reflected the inequalities in terms of access to IT and being able to keep in touch with family and friends over the internet. And they were less likely to receive 4 items or more of offline learning compared to their peers in the rest of the UK. But the projections for the impact of this on a child's future were really stunning. So for example, loss of education was estimated to have a cost of about £24.6 billion across the working lifetime of our children. And the mental health impact was estimated to cost about £13.3 million in terms of lost earnings over these children's working lifetimes. And these are really stunning numbers, and will surely motivate us all to pick up the baton and run with it. So this is a huge and bewildering area of research for those of us that are not fully embedded in these methodologies and processes. So as somebody who is new to the process, I thought it was helpful to think about what's going on already. Who are the leaders in children's and families inequality research that we can turn to within the North West Coast? Where can we add value to establish programmes of research, and where are the gaps and how might we contribute to addressing them? So as I said, I have to put my hands up and admit that I'm a doctor in a hospital who has worked within the Merseyside region most closely, and my understanding of what rests outside this geographical region is limited, and I'm really looking forward to learning much more about this and how we might learn more about the work that each other's doing, and think about how we might strengthen this through collaborations where wanted and needed. So my work, of course, is most closely with the Liverpool Health Partners when I was the research director at Alder Hey. This is a consortium of the 4 academic centres noted on the slide, the 7 NHS partners noted here, and the Innovation Agency and the Clinical Research Network of the North West Coast. So we do have some reach which extends beyond Merseyside, but it is limited. But I think there is value in us reflecting on the process that they did to develop their strategy, and to consider whether we would want to adopt some of the priorities that were identified through this process, or whether we should undertake a different process within ARC. But to give you a little bit of the background, these areas of priorities were developed through 2 rounds of questionnaires, which looked at the different areas indicated on these slides. And this was followed up by a number of workshops which really tried to refine the priorities and think about ways in which they could be implemented. And this work identified 3 domains and 5 programmes, which are indicated here. So we have promoting healthy living, and for example, within the local footprint, we're looking at nutrition and how this links in with obesity, how it links in with the ability for children within Alder Hey to comply with things like the renal diet, recovery from eating disorders, etc. Then there's a theme looking at mitigating and preventing adversity, and this links closely to work going on in ACEs. Promoting positive mental health and well-being, and you'll be hearing from Paul Moran, my colleague, about the ways in which he's looking at the impact of the COVID pandemic on the mental health of young people. Tackling chronic inflammatory and infection-related disorders links in with an area of research which is going on locally, for example, looking at air pollution and presentation to hospital with respiratory disease, and implementing coordinated care looks at some of the complex conditions we have within our secondary and tertiary level services, but also how do we link all the resources which are available to children together to think about how we can make sure they have the best health outcomes possible. So I've just given this slide to show how the Starting Well group has started to grow these themes, but of course this is just an example and a proposal, and it might be that within ARC we choose to do something quite different. So to close, I would value your thoughts on the proposal to adopt the priority areas of Starting Well and to grow these within HaCAL. To think about how we find the key research leaders within our North West Coast footprint, and to think about whether there's any value to looking at disciplines, looking at the disciplines that are leading research, and wondering whether further collaboration might be helpful. And I'm thinking particularly here about my clinical colleagues, my paediatric colleagues, who are very keen to get involved, but need to understand much more about work which is being done in social care, for example, and the social sciences. And then very importantly, of course, how do we ensure adequate representation of children, young people, parents and carers in the development of the strategy? So thank you very much indeed for your attention, and I look forward to receiving your comments.
Hi everyone, my name's Paul Moran. I'm one of the public advisors and co-theme lead for the HaCAL theme. I'm here to speak to you today about health equity and inequalities. And I've read recently that health equity means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographical location or socio-economic status. I can only give my opinion on this as someone that delivers a service for young people in my community on a daily basis. As a boxing coach, I've had to understand the needs of every individual child under my care, and I have a big responsibility. I take a child off a parent for 60 minutes per day, and until I pass them back, I'm in charge of their wants, their needs, and their care ultimately. I need to know their long-term needs, how they feel that day, what has happened in the last week, and whether they have any injuries or illnesses that I need to know about. And I need to know about that for 20 plus kids in any class at any one time. We have kids in our boxing club who've got autism, ADHD, Asperger's, and a number of other words that, do you know what, they and I don't really understand. I need to know how they like to be communicated to. I like to know how they like to learn. So are they a practical learner? Are they somebody that learns by talking and asking me questions constantly? Are they somebody that likes to see it on a board and just read it and kind of take the information in? You know, it's one of those things. I need to know what to spot and know when they've got a problem. And I need to work on it with a combination of the parents or caregivers to fit my style to the best individual needs of that individual child. I need to be an expert in questioning. I need to be an expert in listening. And it's not just hearing the children, but it's really listening to each and every word that they say. And no matter how many times they say it. Because some kids will just ask you over and over and over again until it gets, you know, in their heads. And that's just, you know, different kids, different styles of learning. One thing is, it's really, really difficult. I'll be honest, and some coaches don't have the patience or the skills to handle big groups or small groups, and it really does take a kind of a certain individual and a certain personality to come and do this for free. I haven't been through any official training through our governing body or any medical kind of association. I haven't been to university. I haven't gained a degree, and as I say, I'm not paid to be there on a daily basis. I turn up because I get out of it as much as the kids get out of it. What I am though is I'm a dad, and I've learned a lot from being a father myself. I learn from the kids and the parents every day. There's always something that comes in that surprises me. And I really care. I care about the providing these kids with better outcomes, whether that's kind of physical fitness or better dexterity, whether that's mental well-being being improved, or whether it's better outcomes emotionally just for that hour a day. If it's a little bit of fun, that's kind of all I can do and all I can give to the kids. I can honestly say in the last year that I've probably had 4 referrals to the boxing club, 4 kids that either want to learn boxing or need boxing in their lives because it's, you know, it's good to get that kind of frustration and anger and kind of problems that they've got in their daily lives out to them. I've never spoke to any medical professionals. I've never had a social prescribing from any person in the NHS, but I have had kind of people referred to me. What I'd really like is for kind of these type of things, boxing, football, swimming, running, whatever it is, to be kind of part of the solution, to kind of, you know, fixing some of these kind of health inequalities. And there's people out there like me that are willing to help if you give them a chance and an opportunity. That's just my thoughts on it. As I say, I'm not medically trained. I'm by no means an academic, but you know, I think by giving the service that I provide on a daily basis to these kids, I've got to and I want to have a say in what happens going forward. Thanks very much for listening. Cheers. Bye.
On mute. Thank you very much, everybody. So just want to ask colleagues, thank you very much for those presentations. Any questions, because everybody's on, who made those presentations? Any comments, questions from colleagues? Please put your hand up or note something in the chat. Or do you want to pick up ideas from earlier on when I started the discussion about what we can do in the theme around ensuring that we are addressing equity, and we're using the term equity rather than inequality, because it's wider than just thinking about health inequalities. It's also about how we make sure that our teams, our collaborations are equitable and address different groups and individuals.
Peter's put something in the chat. I don't know if Peter wants to talk. Peter Lloyd?
Can't hear you, Peter. If you've got your video on, turn it off and try again. Or put the question in typing and we'll pick it up. Sorry, you're still suffering from St. Anne's internet.
He's made some comments in the chat about Marmot health inequalities.
Right, there we go. Okay, as awful. We can't really hear you, I'm afraid, Peter. It sounds just very tinny and not possible to follow any words. I really apologize. There was a question, but what the point you're making is about the Marmot health inequalities approach, give every child the best start in life. And it's, as you rightly say, it's about the whole environment in which we bring our young people up in the UK and beyond, I guess. But for us, we're focusing on the Northwest Coast, and it's well beyond just health and even health and social care. It's all about the environments that we produce. I think it's also about social media as well. Not just the physical environment, it's the educational environment, it's the intellectual environment, it's the virtual environment that I think we also need to be thinking about. Sorry, I don't know if it's just me, but we really can't hear you, which is a great pity. Yeah. So Sarah, you wanted to make a comment. Do you want to come in?
I can do. I was just going to follow up on trying to translate for Peter, because we're both health geographers. So I thought that he was talking about the physical environment, and I was just posting some links about the place-based longitudinal resource and the assets to healthy assets. What's it called? Access to healthy assets and hazards, the AHA index that one of my colleagues, Mark Green, has done. And of course, the place-based longitudinal data resource, which takes them through changes in the physical environment. But as you quite rightly said, Mark, it's more than that, isn't it? It's the educational virtual environments as well. Yeah. So we need to take it all into account, really. Yeah. And coming back to data, I'd like data on household income and just some simple things like that.
Yeah, absolutely. Right, we need to wrap up. So thank you very much. Can I remind colleagues that we have this mental health capacity building project that we're going to be helping co-host in this theme with Impact and with other colleagues across different themes. So please do bear that in mind. And if you wish to be part of that development group, then join the round table. Let us know. Can I also remind colleagues that we have our sub-themes, and we have another theme meeting coming up. And also to highlight, thank you, Paul, that we are also want to look at adolescent mental health. And so Paul's setting up some, in the future, we'll be setting up some meetings to look at how we might do that, and it links into our seldom heard voices. So thank you very much, everybody.